Hello everyone, in this video we are going to understand the different types of pulse and arterial pulses and their abnormalities. So let us begin with making the diagram of a normal pulse. So a normal pulse wave would be something like this. This section corresponds to the ventricular contraction. Whenever the left ventricle contracts, it pushes blood to the systemic circulation, and that results in creation of this pulse. The blood that has come out of the left ventricle into the systemic circulation, it essentially distends the arterial wall and gives rise to this pulse right here. So this pulse is known as the tidal wave. Now, as the amplitude of ventricular contraction progressively starts to decrease, the pulse wave, the pulse pattern, the pulse tracing also starts to decrease, and we get this descent. Now what happens is, there is the beginning of this phase of the pulse, which is known as the percussion wave. And it is said that this percussion wave is contributed to by the systemic circulation, that is the peripheral resistance. Okay, it is the systemic circulation or the peripheral blood vessels that contribute to the percussion wave. And as the heart contracts and a tidal wave is formed, the amplitude of the ventricular contraction progressively starts to diminish, which gives rise to this fall in the tracing of the pulse. This part is corresponding with the blood going into the systemic circulation, and now the systemic blood vessels, they also provide some resistance to the blood flow, which gives rise to this portion of the pulse wave, which is known as the percussion wave. And there is this notch present between the pulse, which is contributed to by the heart, and the part of the pulse wave which is contributed by the systemic circulation, and this right here is known as the dichotic notch. So this is basically the normal tracing, that this is basically what a normal pulse looks like. Let me also tell you that from beginning of the left ventricular contraction up to the completion of the systole, this corresponds with second heart sound, this corresponds with the first heart sound. Okay, so this is basically happening during the systole phase, as we have already understood. And this part of the pulse tracing is happening during the diastole phase. Again, another pulse wave will begin from here, and a similar pattern of tracing would be formed in a subsequent pulse. So this is a normal arterial pulse. Now let us talk about some abnormalities of the pulse. The first abnormality that we are going to talk about is a weak pulse. Okay, so let's say the amplitude of this pulse is compared to the amplitude of this pulse compared to the normal pulse that we made here is low. The reason is that the amount of cardiac output coming out of the heart is less. So what might be the condition where you might expect a rapid and feeble pulse? Definitely it's shock. Okay, in cases of hypovolemic shock, we will expect a slow, a small peak, rapid and a feeble pulse, right? Contrary to that, if there are large bounding pulses like this, the amplitude of the tidal wave is more. That means the heart is pushing out more blood. This is a high cardiac output state. So what would be a condition of high cardiac output? Fever would be one, hyperthyroidism maybe another, maybe in children after exercise, maybe physiological, right? Maybe in Paget's disease of bone. Okay, so Paget's disease of bone. So these are some high cardiac output conditions where we can find this type of large bounding pulses. Okay, these were the easy pulse abnormalities to understand. Obviously, we have an abnormality in the rhythm of the pulse. Both tachy and bradycardia are abnormalities in the rhythm of the pulse. Sorry, in the rate of the pulse, and if there are abnormalities in the rhythm of the pulse, we usually diagnose it from the ECG, which is beyond the scope of this video. But let's talk about different other types of pulses. So let's look at this pulse. Let's examine this pulse. Let me make a demarcation for S1 and another demarcation for S2. And let us say that there is a tidal wave. This tidal wave should start to decrease, and once the ventricular contraction is over, the aortopulmonic valves, and right now the valve of our concern is the aortic valve. Once the aortic valve is closed, this part of the pulse is contributed by the systemic circulation. So this is a normal tracing. We've already discussed about this before. Now imagine this. Okay, imagine this. Let us say that there is a pulse that progressively goes up and it quickly comes down. Okay, so before, like normally it would have come down here like this, but it is quickly coming down. So it is quickly coming down, but there is a double peak. There's another peak, and now it is going down like this. Okay, so let us say that you get a pulse tracing like this, and this type of pulse tracing is known as pulsus bispheriens. Please do not confuse this with pulsus bigemini. I'll talk about bigemini later on. So pulsus bispheriens, I'll tell you what the mechanism is. If you understand this, you'll never have a problem with pulsus bispheriens. Okay, so let us say this is seen in a hypertrophic obstructive cardiomyopathy. So basically what is happening is, this condition is also seen in aortic regurgitation. Mechanisms are quite similar, but there is some difference between the two. So I'll talk about both now. So what is happening in hypertrophic obstructive cardiomyopathy is basically your ventricular septal wall is left ventricular septal wall is too thick, but this part of the septal wall is non-functional, it is non-contractile. Okay, so because of it being thick, whenever you are trying to push blood out, what happens is obviously when you start to push blood out, there is an initial gush of blood that goes out of the ventricle, which leads to the formation of this tracing, right? But what is the cause of this tracing to start to fall down? Okay, the cause of this tracing to start to fall down is because this hypertrophied segment of the left ventricular septum will create an obstruction to the outflow. Okay, so what is happening is, initially your ventricles were distended by blood. Okay, because there was blood during diastole, the blood fills into the ventricles, and as the left ventricle progressively started to contract, the ventricular walls also started to oppose, because of which the space between the ventricular, basically the ventricular volume or the ventricular space started to get narrowed. Okay, so now once it has started to get narrowed, this extra amount of tissue in your ventricular septum is now creating an obstruction to the flow, and so that is the reason why you will start to see a decline in the uh, in the pulse. Okay, but this is still happening in systole. I need you to understand, this is still happening in systole. That means the ventricles, they have not contracted yet, they have not completed their contraction yet, they have not completed systole yet, so they will still continue to contract, and that is the reason why there is another peak. And mind you, this peak is again within the systole itself, and so there are two peaks in the systole, and this is known as pulsus bispheriens. Let's see what happens in aortic regurgitation. So suppose this is your aortic valve. Obviously you have your atrium, left atrium, and your left ventricle. So what is happening in aortic regurgitation is, during systole the blood starts to go, the ventricles start to contract. So definitely your left ventricle also starts to contract, and the blood starts to go out. Okay, so the blood starts to gush out of the heart into the systemic circulation. So generally if you start with the pressure of 0 mmHg in the ventricles, let us suppose, up to 80 mmHg of pressure is when your ventricles will push blood out. It will continue to push blood out, but the amplitude of ventricular contraction will start to decrease, and there will be a point when the pressure inside the aorta will be more than the pressure inside the ventricle, and that will cause that will actually push the aortic valve leaflets below, and that will cause the closure of the aortic valve, and that is what normally happens in a normal cardiac cycle. But what is happening in aortic regurgitation is, let us make this diagram again. So you have your aorta and you have your ventricles. So once the ventricles start to contract and once the ventricles start to push blood, your aortic valves will open and the blood will start to go out. Okay, so let's say at the pressure of 80 mmHg, obviously the ventricular contraction, although it is still contracting, the amplitude of ventricular contraction starts to decrease, and even a small decrease in the ventricular contraction causes a backflow of blood. It will cause the blood to backflow into the heart, and because your aortic valves are not competent, they prolapse, right? And that is what is happening in regurgitation, right? The aortic valves cannot stop blood, sorry, they cannot stop the blood coming from aorta to the ventricle. So what is happening is, because of the incompetence of the aortic valve, the blood will start to go back to the heart, causing this tracing. Now again, the same concept as in HOCM, the heart is still in systole, the heart is still contracting, the ventricles are still contracting, and the ventricles have to do much more work, but they eventually push blood outside. Okay, they will eventually push blood outside of the ventricles into the systemic circulation, creating another wave, another peak in the wave. And so this is again a wave that we feel within the systole itself. This is known as pulsus bispheriens. So I have told you what pulsus bispheriens is and what are the mechanisms, what is the mechanism of pulsus bispheriens, and what are the conditions where we can see pulsus bispheriens. Now let us talk about another condition similar to this. So that is the reason why a lot of us are confused, but there's no need to be confused. Okay, I'll explain this condition to you. So let us see what is happening here. So normally there had been a tidal wave, then a dichotic notch, and then a percussion wave, right? So this is a normal pulse. Imagine in this condition you get a tracing where there is an increase in the tidal wave, slight decrease. So normally it is, it's progressing normally, and in the percussion wave you again get another bump. Okay, in the area of percussion wave, so this is the area of percussion wave, so this is the percussion wave, this is the tidal wave. So in the area of percussion wave you again get a bump. Okay, and you feel like there are two heartbeats. Okay, so basically when you palpate, you will feel like there are two beats in the same beat essentially. But obviously you may not be able to, like, we may not have the clinical acumen of differentiating between all these pulse abnormalities just by palpation alone. So maybe you have made a tracing and you can see this. Okay, so you clearly see that in the area of percussion wave there is another bump. So what might be the cause? The cause is a premature ventricular contraction. What is happening is, normally this is systole. This portion right here is systole between S1 and S2, right? And this portion right here is your diastole. So this is your systole, this is your diastole. This is the portion where, this is the part of the cardiac cycle where your heart should have contracted, and this is the part of the cardiac cycle where your heart should have relaxed. What is happening here is, in diastole itself your heart is contracting, and that is because of a premature ventricular contraction. It's a premature ventricular beat. And if you have studied ECG, we classify premature ventricular contractions according to bigeminy and trigeminy and things like that. So we use the term bigeminous. We use bigeminic. Why we use the term bigemini? So this pulse right here is known as pulsus bigemini. So this is pulsus bigemini. Okay, so again this is seen in premature ventricular contraction. Okay, so you understood this also. Now let us talk about another type of pulse abnormality, which is known as pulsus alternans. So imagine this, a normal tracing of your pulse. Again we get the memo, right? I'm drawing this again and again so that you get familiarized with the concept of tidal wave and percussion wave. So we have S1, we have S2, again we have S1. So this is your diastole, this is your systole, and again we have another beat. So you have your systole here. So this is your diastole, this is your systole, again another diastole, and a systole again. So let us say during systole you have a tidal wave, you have a tidal wave, progressively decreases, you get a dichotic notch, there is a percussion wave, again there is another systole. From here there is a tidal wave, there is a dichotic notch, there is a percussion wave, again there is a systole. So this is what is normally happening. So I think the tracing is not quite exact for this. Okay, so imagine this is what is happening. Okay, so this is what is happening normally. Now you get a pulse where you get a tracing where in one beat you are getting a normal amplitude of both the tidal as well as percussion waves, but in the second wave you see something like this, and in the third wave it's a normal wave again, and this continues. Okay, so one of the waves is normal in amplitude, in everything, it's normal in amplitude, character, everything is normal, but another wave is small. Subsequent wave is normal, another wave might be small. So this alternating pattern of wave is known as pulsus alternans. And if you have studied ECG, this would be our normal ECG tracing. So this would be a normal ECG tracing, let us assume. Okay, so we have a T wave and a U wave. So imagine this is your P wave, this is your QRS complex. You have a T wave here and a U wave here. Again P wave, your QRS, a T wave here and a P wave here. So imagine this is the normal. If you get a tracing like this, a normal amplitude of like ECG waveforms, and then you get this particular ECG picture. Again you get a normal ECG waveform. So imagine this. Okay, so this is a normal ECG waveform compared to this, but this right here has a decreased amplitude. Okay, so this waveform right here has a decreased amplitude. This alternating pattern of ECG tracing is also known as electrical alternance. The reason why I mentioned this is because I wanted to tell you the similarity between an ECG tracing as well as a pulse tracing. But the difference here lies in the fact that this pulses alternance, it is caused by a condition known as left ventricular failure. And I'll tell you why. But this electrical alternance is caused by any fluid collection around the heart. So what might be a fluid collection around the heart? Obviously it would be a pericardial effusion. It will be a pericardial effusion. So this pericardial effusion causes alternating electrical waves. The heart is normal, but because of the fluid that surrounds the heart, it changes the amplitude of the electrical waveform. So sometimes you get a normal amplitude waveform, sometimes you get a small waveform, sometimes you get normal, sometimes you get small, and that is known as electrical alternance. That is a characteristic finding in pericardial effusion. Compare that to pulsus alternance. The concept is same. Sometimes you get a normal amplitude of pulse waveform, sometimes you get a smaller pulse waveform, then again you get a normal amplitude of pulse waveform. But this is seen in left ventricular failure, not in ectopic beats or not in premature ventricular contraction. Why? Because in premature ventricular contraction you get something known as pulsus bigemini. I've already raised it, but you know. So you've understood the difference between pulsus alternans and pulsus bigemini. You have understood the difference between pulsus bispherians and pulsus bigemini, right? So what is why is there pulsus alternans in left ventricular failure is because, let us say, during this systole, because of left ventricular failure, the left side of the heart could not pump all of the blood outside. So the ejection fraction of the left side decreased in this systole during this phase of the cardiac cycle. So during this phase of the cardiac cycle, during this systole, not all of the blood from the left heart could be pumped out into the systemic circulation. So what does that mean? That means that all of the blood during this systole that could not come out of the left ventricle remained accumulated in the left ventricle itself. So it is being accumulated in the left ventricle itself. So what will happen to this blood? So this blood which has remained accumulated in the left ventricular itself, in medical terms this is known as end diastolic volume. So end diastolic volume is increasing, right? End systolic volume. So this is known as end systolic volume. End systolic volume is increasing. So because end systolic volume is increasing, that is at the end of the systolic contraction, the amount of blood that remains inside the heart is increasing. It is more than what should have normally been. That means if the end systolic volume is increasing, you know that the preload for the next contraction has increased. Okay, there's a lot more blood inside the left ventricle for it to push, right? So because there is more blood for the left ventricle to push, the amplitude of the second contraction will be normal. But again, this is basically because of an increase in preload. So based on the Frank-Starling principle, if there is an increase in preload, there is an increase in afterload. So the subsequent contraction will be normal. Again, this cycle will continue as long as the left ventricle is competent enough to push blood out into the systemic circulation. So this cycle will continue, giving rise to something known as the pulsus alternans. So we have understood what a normal pulse is, what an abnormal pulse is, and we also understood what electrical alternance is. Now let us talk about pulsus paradoxus. I have nothing much to say about pulsus paradoxus in terms of pulse tracing. Okay, it looks something like this. I have nothing much to say about pulsus paradoxus in terms of pulse tracing, but what I want you to understand in pulsus paradoxus is, number why, what is pulsus paradoxus, and why is this known as pulsus paradoxus? Because we know that pulsus paradoxus is a drop in systolic blood pressure of more than 10 mmHgs. So if there is a drop in systolic blood pressure of more than 10 mmHgs during deep inspiration, if there is a block in systolic blood pressure more than 10 mmHgs during during deep inspiration, why would it be called as pulsus paradoxus? Why would it have the name of pulsus? It must have the name like it would have been named as maybe pressure paradoxus or something like that. And why is this paradoxical? Okay, this definition does not explain why this condition is known as pulsus paradoxus. For that, we need to understand what is the pathology and what is the pathogenesis behind pulsus paradoxus. So the pathology behind pulsus paradoxus is, there are many causes of pulsus paradoxus. Even asthmatic patients with acute severe asthma, they can have pulsus paradoxus. Maybe a COPD patient with perihilar, maybe Blebs or Bulle, they can have pulsus paradoxus. But let us talk about a condition where there is a constrictive pericarditis. Okay, so let's say there is constrictive pericarditis. All the like there might be different pathologies, but the mechanism is the same. What is happening is, this constrictive pericarditis is constricting the left ventricular. So if this is the, let me make a better diagram. So if this is your aorta, this is your ventricle, and this is your, sorry, this is your atrium, this is your atrium, this is your ventricle, and this is your aorta. The ventricle pushes blood into the aorta. This distends the aortic wall, and the aorta becomes distended. And during ventricular systole, when the ventricle is filling, the aorta contracts and it pushes blood into the systemic circulation. So this initial pressure was known as systolic blood pressure. The latter pressure is known as diastolic blood pressure, and this effect is something known as Wind-Kessel effect. Wind-Kessel effect, right? So this was the brief review of normal physiology. So what happens in constrictive pericarditis is that there is a constriction. There is a constriction around the heart. Okay, there is a constriction around the heart. Okay, so if there is a constriction around the heart, do you think that the heart can normally, during diastole, it can normally dilate and it can fill normally? No. Why? Because this constriction is pushing into the heart, right? Because this constriction does not allow the heart to fill normally. So if the, again the same thing, if there is a decrease in the end diastolic volume, there will be a decrease in the stroke volume. If there is a decrease in the stroke volume, there will be a decrease in the heart, sorry, in the blood pressure. Why? Because blood pressure equals to cardiac output into total peripheral resistance, right? Cardiac output is determined by stroke volume and heart rate. So if the stroke volume is decreasing, the cardiac output is decreasing. If the cardiac output is decreasing, the systolic blood pressure is decreasing. So that is what is happening in constrictive pericarditis. So that causes a decrease in the systolic blood pressure. But why do we say that the decrease is more than 10 mmHgs? For that, we need to understand another normal phenomenon, that during inspiration, what happens is, whenever we inspire, there is an increase in the cardiac venous return. As there is an increase in the venous return, the right atrium will start to fill up more, the right ventricle will fill up, and all of this blood will be sent to the lungs. But because of inspiration, during inspiration, what we are essentially doing is, we are increasing the lung volume. So the lung parenchyma also expands, and the lung also has now a capacity of accommodating more volume of blood. Imagine if you have a small polythene bag, you might be able to fit maybe 2 objects, but if you expand that polythene bag, you can now you may now be able to accommodate 4 objects inside. It's the same mechanism. The lungs also expand during deep inspiration, and the lungs will be able to accommodate a larger volume of blood. As the lung starts to accommodate a larger volume of blood, the left atrial preload will start to decrease. And because the left atrial preload will decrease, the left ventricular preload will also decrease. And subsequently, the left ventricular afterload will also decrease. So that basically means that the cardiac output is decreasing. And if there is a decrease in cardiac output, again there is a decrease in the blood pressure. So that is a normal thing. So systolic blood pressure would normally decrease up to 10 mmHg during deep inspiration. That is normal. Please do not confuse this with the criteria of orthostatic hypotension. Okay, in orthostatic hypotension, SBP should be decreased by more than 20 and DBP should be decreased by more than 10 mm of Hg. So this is not orthostatic hypotension that we are talking about. We are talking about pulsus paradoxus. And so that was a normal phenomenon. During deep inspiration, your systolic blood pressure will decrease. But what is happening in constrictive pericarditis is, because there is already a constriction, not just in the left side of the heart, but also in the right side. Left side of the heart, there is a constriction. Obviously, there will be a decreased amount of blood coming into the left side of the heart. But even in the right side of the heart, the amount of blood that comes into the right side is also decreased, because like in normally in deep inspiration your venous return would increase, right? So that happens normally because there is no problem with venous return. The problem is that the right ventricle also cannot expand, and so does the left ventricle. So left ventricle also cannot expand, neither does the right ventricle. So whenever there is a whenever there is a venous return, you ask the patient to inspire deeply, there will be a normal venous return, but all of this blood may not be able to accumulate in the right ventricle itself. So if it does not accumulate in the right ventricle, the right ventricle cannot push it to the left atrium. So whatever the blood that the lungs has, obviously because not a lot of blood is coming to the lungs, there would be two things. So the first thing is, obviously the lungs would have less amount of blood compared to when the right side of the heart would have a normal cardiac output. So obviously the lungs have less amount of blood, number one, because of constriction of the right side of the heart. The second thing is, whatever the small amount of blood is present in the lungs, it would definitely be accumulated in the lungs itself. So the lungs would not push a lot of blood into the left atrium, so that would further decrease. There is a greater decrease in the left atrial preload. Now again the story continues. If there is a more increase in the left atrial preload, there is a decrease in the left ventricular preload. If there is a decrease in the left ventricular preload, there is a decrease in the left ventricular afterload. So basically the cardiac output will decrease, and now this decrease in cardiac output is more than the normal physiology, and that is why the systolic blood pressure would decrease more than 10 millimeters of mercury in pulsus paradoxus. That is the entire mechanism of pulsus paradoxus. Couple that with a stiff left ventricle. Let's not call it a stiff left ventricle, but a left ventricle which itself cannot expand. Okay, so couple that with a left ventricle which itself cannot expand because of constriction, and so there is a greater decrease in the systolic blood pressure, more than 10 mmHg, and this is known as pulsus paradoxus. But this still does not tell us why this condition is known as pulsus paradoxus. Now see, what is happening here is a normal pulse pressure. So I'll write it in a different color. A normal pulse pressure is calculated by systolic blood pressure minus diastolic blood pressure. So it is calculated by this formula: systolic blood pressure minus diastolic blood pressure. Generally it is 40 mm of Hg. So like for example, a normal blood pressure would be 120 by 80. Difference between 120 and 80 is 40, right? So normal pulse pressure is 40 mm of Hg. So when there is a normal pulse pressure, that means normal pressure inside the arterial system, you will feel a pulse. But what is happening here is the systolic blood pressure is starting to decrease. As the systolic blood pressure starts to decrease, it will become more close to the diastolic blood pressure. So if there is a decrease in the systolic blood pressure, by the laws of mathematics, if there is a decrease in the systolic blood pressure, obviously the pulse pressure will also start to decrease. So if there is a decrease in the pulse pressure, will you be able to palpate this pulse peripherally? No. You will not be able to palpate this pulse peripherally. But does that mean that this patient does not have any pulse? No. This patient has pulse. This patient has this patient definitely has a cardiac output, but you will not be able to palpate his pulse. Okay, so you make the patient inspire deeply and you start palpating the pulse will disappear. And this paradoxical disappearance of the pulse because of a decrease of systolic blood pressure of more than 10 mmHgs is known as pulsus paradoxus. So I think I have definitely tried my best to make you understand the different abnormalities of the pulse and the normal morphology of the pulse. So if you have any doubts, if you have any, I know this might be confusing, but if you practice it by your own one or few times, a couple of times, and if you teach this to someone else, you'll be able to master this in no time. So this is not an extremely a rocket science. So this is a very simple concept, but for this I would say that you should have a prerequisite knowledge of the cardiac cycle. To understand cardiology, you need to have a prerequisite knowledge of cardiac cycle. So if you've understood cardiac cycle, you'll understand murmurs, you'll understand pulses, you'll understand other different pathologies. So you'll understand so many things. So you need to understand what cardiac cycle is, what are the components, what happens, what goes on. So if you do that, and if you watch my video and if you practice it a couple of times, I think you'll be able to master pulse and its abnormalities in no time. So thank you for watching this video. Have a